So we're going to bring all the speakers up, as well as the chairs, and we'll have an open Q&A panel here. If people could use the microphones to ask your questions. And we have blinding lights here, so I think I can see who's at the microphones if I do this.
Yeah.
So I see someone on the right. Go ahead.
So I work in a hospital in Brooklyn, New York. I just move forward. Okay, thank you. So I just wanted to share what's going on in my hospital. In our hospital, about 20 to 25% of the pregnant women have a positive history of travel to a Zika active area, like the Caribbean. I'll give you an example. They typically spend the first 20 weeks or 28 weeks, let's say, in Trinidad, and then they come over to our hospital for care. If you look in the clinic on any given day, like you have 30 patients, about 8 patients have an active history, travel history. And we're not testing them. And the issue is our OBs have decided not to test them because the system in place to test them is very cumbersome. For each patient that needs to be tested, somebody has to go on the phone and get approval from the DOH. So they say it's not doable, we're not going to do it. We've talked to DOH about it. They're saying they're going to come up with a system that'll help us. So, but again, my concerns that come from the situation is, one, do we have an answer to what percentage of women with a positive travel history in the US are actually testing positive? That's question number one. And number two is related to the fact that in infants, the protocol says if the mom is not tested and the baby does not have microcephaly, don't test the baby. And if, as one of the speakers brought it up, if microcephaly is just the tip of the iceberg in infants, then we're going to miss the rest of the iceberg. And should the protocol be any different when moms are not being tested?
Who'd like to take that one?
I think it's a CDC question.
I think the recommendations are to test women who have had travel histories. I realize that the system is not completely worked out in some states yet, and in some of the local health departments. I think the state and local health departments are improving their ability to test, and so I'm hoping that your group will reconsider the testing and keep working with your local health department to get that done, because I do think that's important. I think that we are assuming that women are being tested, and that was what our recommendations for babies is based on. We talked a lot. We talked with the AAP, our AAP colleagues about this, and decided that, you know, if you have a baby that presents to you and the baby looks just fine and everything that you do is a normal physical exam, that doing additional testing wasn't necessary if the mother had either tested negative or hadn't been tested at all. I guess if there are large proportions of people that are not going along with our advice to test women who have traveled, I think then you need to reconsider testing of the baby. I agree.
I just want to add something. The ACOG is only saying for women who have not been symptomatic during pregnancy and have traveled to Zika active areas, they're only saying consider testing, or use it as an option. And number two, when you talk to DOH, none of Brooklyn is getting tested, but in Manhattan, if a journalist spent 3 days in Columbia, she asks a doctor and she gets tested. So there's going to be disparities in what's going on, and it's interesting to know that CDC doesn't know what's really going on.
Okay, well, I think they know a lot, so I
true.
think we're doing pretty well from the CDC standpoint. But I was going to add to that, with the recent release of this emergency use availability of the focused diagnostic test, do you think that will change the availability and perhaps the practices of some folks in the
Yeah, I
US?
think it is going to make testing much more available. I think we have been working from the very start to help state and local health departments to have that testing available in their health department so they aren't depending on testing coming to CDC. And I think most state and local health departments have really made a lot of progress with that.
And that literally just happened last week, so, you know,
The PCR
we need to give it a
testing.
little bit of time.
Yeah.
Okay, let's take another question on the left here.
Yeah,
Go ahead.
So I'm Sally Permar from Duke, and I've been working with the group at Wisconsin, David O'Connor, who's been developing a non-human primate model for Zika virus infection, and the non-human primates do get infected with Asian and African lineages, which is not surprising. The non-pregnant animals remain viremic for about 7 to 10 days, and some new data, and this is all being posted online, actually, so it's really supposed to help the community. The most recent data is that upon reinfection, the animals have not become viremic within a week when all the other animals did. But the most interesting observation to me is that in compared to non-pregnant monkeys that are only viremic for about 7 to 10 days, the pregnant monkeys have been viremic for out to more than a month. And so I'm wondering if that has been seen in humans. I know in the one New England Journal paper that was reported, but whether you're seeing prolonged maternal viremia in addition to this infant that you reported as well.
You know, we were shocked by that in our case. I mean, it was 10 weeks of persistent viremia, and I didn't mention, but after she was tested, several weeks after the pregnancy was terminated, she became aviremic. So the idea is that that fetus was the nidus of this prolonged high viremia, and that goes along with some of the data that Karen presented. So I think those studies are in many other studies being looked at, both serial PCR in women and also quantitative PCR to see if that can be a biomarker of an affected pregnancy or not only infected but affected baby because of the high amounts of virus that you could cultivate from the brains of our affected fetus. Anyone else want to comment?
Just one comment in line what you shared. It's just an ecological observation, but the places where we had a huge activity of the virus last year in Brazil, currently we are not seeing those high number of cases. It appears that after circulating in the next year, it appears that the susceptible population was exhausted. So it may be a clue to drive the concept that maybe we induce immunity, at least short-term immunity after being infected. So this is something that we should look for closely to really understand.
Just a short comment. We have collected convalescent serum and actually urine 30 days after the acute infection when women were symptomatic. We have not run those PCRs because the priority is to diagnose the women, and when there's a backlog, we still have PCRs that need to be done for women whose babies are being delivered because, you know, there's a limit of resources in Brazil right now, but we should have that data at least to know if they're viremic for 30 days. I don't believe so, at least in the initial cohort, because we were seeing that they wouldn't be viremic anymore and only the urine was positive. But we have the resources. We're going to test the specimens we have, and we should be able to address that.
Let's take a question up here.
Maggie Hammerschlag, Brooklyn, Downstate Medical Center. I just want to point out that the Department of Health, the New York City Department of Health, has prepared a set of guidelines that are very detailed because I was part of a expert panel on that in February, and I think it will be very complete, and they've looked into availability of testing, and so we'll put that aside. One other issue, and I just think looking at the history of this, so it was discovered in Uganda 60 some odd years ago. Ostensibly, it's been circulating in Africa. We don't know for sure, but obviously there are other zoonotic infections that get out there, yet nobody has reported on any kind of an outbreak or occurrence of microcephaly. Has anybody actually done any population serosurveys there? I mean, they have? Okay. Because obviously, I mean, even with chikungunya hitting the Caribbean, you had this big burst of activity 2 years ago, and then it kind of disappeared. It was no second wave. So whether this is a one-time event or is this going to be a continuing event?
Any comments from anybody on that one?
Well, I think one of the questions we always hear is whether the virus has become more neurotropic and if there's a difference between the Asian lineage and the African lineage, which is different. I mean, as far as we know, there were no reports from Africa coming out, but maybe they were just not identified. There are some investigators looking at the sequence of the virus. It's a very conserved virus, but maybe there are very small amino acid changes that might confer some increased neurotropism in these Asian lineage strains. So people are looking into that.
I was going to say, I didn't mention this when I briefly presented our case, but the CDC colleagues did sequence the virus isolated from our patient, and there were amino acid changes, one of which was a reversion to African. So what that means, we don't know, but it's certainly an area of interest. Over here on the right.
I'd like to hear some comment about the mosquitoes being resistant to the insecticides that are used in spraying and how that's going to be tracked.
Yeah, our arboviral colleagues are looking at resistance, and they are finding high levels of resistance to certain insecticides in Puerto Rico, and that will be continued to be looked at as the outbreak goes on, as we expect that there will be potentially an outbreak in the U.S. as well.
But you haven't made any changes to spraying programs in Puerto Rico at this point? That's an evolving issue?
We're using the most effective. So we've looked at all the different kinds of insecticides that are available, and we're using the ones that are that have the least level of resistance. Yeah, we're definitely using that as guiding our insecticides.
I'm going to go to the back corner there again.
Sorry, the one problem with the insecticides and the repellents is also they are short-term viral life. So most of them, after 2 to 3 hours, they are not working. So this is an issue, except icaridine, which you can expect like at least 8 to 10 hours of action. And just to mention, it disappeared from the pharmacies in Brazil. When we had the outbreak, everybody went to the pharmacy to do stockpiling of icaridine, and it disappeared from the pharmacies. They were not able to supply the amount of icaridine, and the other repellents, they are definitely very short term, so after a few hours, you are already susceptible to the mosquito bite.
Go ahead.
Hi, Marianne Lofrumento from Morristown, New Jersey. I do medical work in Haiti. I had the pleasure of having Zika in January. I was one of 8 of our volunteers who got it during what was pretty much wasn't even in the press yet, and it was in early January. And thank you for that New England Journal article, because there's very little written about those who are not pregnant getting it. And I would say that of all the 8 of our volunteers who had it, we don't like the word mild in front of it, because it actually was a pretty rotten 3 weeks. You know, we had the whole list of the symptoms, not with the dire consequences. But now that happened, everyone had it in Haiti. We talked to a lot of our workers there, our volunteers who had access to medical care, and then it seemed to disappear again. And yet we're trying everything we can now to protect our pregnant women in our clinics, bringing massive amounts of DEET down for them to wear. I don't know if any of this is going to work. We won't know yet until the fall whether there was an issue or not, but it seems they're not seeing it in the clinics that we have continuing there amongst the Haitians that they're seeing. We have had about 100 volunteers go with our organization since then. No one has gotten it. One person got dengue, but no one has gotten Zika. We've eliminated anyone who is potentially pregnant from going at all, or and giving them the choice if they're of childbearing age, and doing all the cautions. But it does seem to have come in a 2-month really strong wave, maybe getting those of us who were more naive than others. So I don't know if this is what's being seen in some of the other islands. There's very little data in Haiti right now, because there's virtually no system, like even in Brazil or anything, to do some really good extensive field work.
How about in the back there?
I'm David Rechtman from Industry, California.
I'm sorry, did you want to comment?
No, just one comment. The outbreak is now 1 year, less than 1 year. So these kind of things we will learn from now on, this kind of lifelong immunity and what happened. Maybe those patients can be reinfected, but without viremia. So these are things that we definitely will learn from now on, because it's the very first year of circulation of the virus. And besides that, regarding vaccine trials, it will be a real challenge to look for efficacy in a vaccine trial, if this is true. How would we be able to perform an efficacy trial of a vaccine in the field if we assume that the population will acquire immunity in those endemic settings? We will have to look for a population still naive and etc.
Okay, go ahead.
I'd like to bring the conversation back again for a moment to the issue of assays. And I understand that CDC and the various state and local health departments are working under a, for lack of a better term, special dispensation from the FDA to use an experimental assay, and therefore it has to be restricted. But clearly that is not going to be a tenable situation, particularly as sometime between now and who knows when, someone is going to decide that, gee, we need to protect the blood and plasma supply, we need to protect the breast milk supply, and everybody needs to be screened. So does anyone on the panel have any idea what the status of developing a commercially available assay for Zika is?
Yeah, I think what you were speaking about, Dr. DiBiase was talking about, was that there has been a commercial assay for PCR that was approved this last week by FDA. I won't say the company because that would be sounding like I was endorsing the company, but there is a commercially available test already available. There actually is testing already of the blood supply in Puerto Rico going on. So those sorts of tests, you know, a lot of work has been done in a very short amount of time. When you think about how much work has been done, as you say, from an outbreak that started, you know, about a year ago, a lot of work has been done, including commercially available tests.
And the commercially available test that was just approved is a PCR, but they've talked about an IgM will likely also be approved shortly.
Yes.
So if demand occurs, which I'm pretty sure it will.
Yeah.
So. Okay, up here, up in the front, anyone? Yes.
Yeah, well, so just a comment on the persistence. Marco, you mentioned the persistence of viremia in the infant. And of course, this does have parallels with rubella and CMV, and just suggesting that one begins to look at cellular immune responses, which we found to be important in shutting off replication of those two viruses in infected infants. And it's just a comment as far as vaccine studies are concerned. Without going into a long song and dance, this is something that is being actively discussed in terms of diseases like Zika, how one would prove efficacy. And of course, in the case of Zika, we have the primate model, which could give us data to demonstrate efficacy. Of course, the FDA would have to sign off on that, but there is an animal rule. And so that is a possibility. And also human challenge studies is another possibility, which of course would have to be done in healthy male volunteers.
Thank you. Up here in the front.
Peter Krause, New Haven. I'm wondering if there have been any long-term antibody studies in patients who've had Zika a long time ago, such as in French Polynesia, to see how long antibody might persist and to see if, therefore, maybe immunity may persist. That's one question. The second question I have is if you have a patient with Zika and you do both the Zika antibody test and the dengue test, can you not do antibody titers for the two? And presumably the cross-reacting antibody will be a lesser titer. And I'm wondering if that would be laborious, but I'm wondering if that's something that could be done.
I think one of the issues with the French Polynesia data is just that many of the studies that came out were based on antibodies, and as far as I know, there's dengue there too, right? So there was a rise in antibody titers, and a lot of the Zika was diagnosed via antibody surveillance, but as you know, because of this cross-reactivity, maybe there is some overestimation of what it is in terms of antibodies. I think the only way that you can do, because at least in Brazil it's been very erratic, you could get very high titers for dengue when you have acute Zika and you're not having dengue because the dengue PCR is negative. I think the only way you could really look at this is doing neutralization, because dengue antibodies are not neutralizing against Zika. You know, you have women who have a lot of dengue antibodies, they have active Zika and they're viremic and so forth. So if the antibody neutralizes Zika, then that's true Zika neutralization from Zika antibodies. I think that's the only way we can look at it right now. And as we design these studies, that's a major concern, a good test. And I think that's the only way we can do it.
Just one comment. We were using the PRNT, the neutralization test in those kids, and if the titers for Zika are 4-fold higher than for dengue, that's the threshold that we use to establish the Zika diagnosis using the neutralizing test.
And that's what CDC is doing.
Yeah. Okay, and just I'm sorry, just in terms of the long-term follow-up, you said in French Polynesia they weren't using PCR, so you couldn't have cases that you were fairly certain were Zika. It just, the concept is simply that you follow patients over a long period of time, or follow up those patients who've had it 10 years ago to see if they still have antibody. And if they do, then that might suggest that there could be some long-term protection. So has anyone done anything like that?
I'm not aware of that.
I'm not aware of that.
Repeated infection.
Thank you. How about in the back
The
corner?
Yap Island reported an outbreak in 2007, also in the Pacific Island, and maybe it's a place where we could do this.
Go ahead.
Josh Wolf from St. Jude in Memphis. My question is about experience in immunocompromised hosts. Perhaps, Marco, you can comment?
Yeah, we do not have experience. We have a few reports in the literature. One came in from Colombia and one death in Brazil. A splenic patient was a sickle cell disease patient in Colombia, was an adolescent that contracted Zika, and she developed a severe acute respiratory syndrome, went to intubation and died. And we have 2 deaths in the beginning of the outbreak in Brazil in immune-compromised patients. So potentially, you are right, immune-compromised patients may have a more severe outcome of the disease, but very preliminary data.
Dr. Cherry, did you want to comment?
Yeah, I wanted to comment. Well, I'm not sure on that, but that Scott Halstead and Science predicted it's going to be over, that the whole population is infected, antibody works, and so next year there's going to be no cases in Brazil and not in Puerto Rico or Costa Rica either. And I'm throwing that out to discuss, but I think it's very important because people are setting up prospective studies and there's going to be no cases.
Yes, apparently we are observing, but remember, Brazil is like US, is a continental country, and we did not observe the same circulation in all regions. It was heterogeneous. So, for instance, in my city, which is the largest city in the southern hemisphere with more than 15 million inhabitants, we so far did not see such huge circulation of Zika. So theoretically, we are still in risk after 1 year. But you are right. Apparently, the places where we had circulation, we are not seeing cases this year.
And the other thing that's of interest is that, and this is based on a Puerto Rican study, that there's very few children reported and less males than females. And the assumption is their illnesses are more mild, which I don't understand why, if that's true, but they're all getting infected, if you believe what Scott Halstead says.
We have some unpublished data in age distribution of Zika cases, acquired cases, and clearly we had the highest proportion of cases in adults. And we have cases in children and adolescents, but clearly the highest proportion of cases is concentrated in middle adulthood.
We're looking
what about
at
neutralizing antibody? I mean, that's the the key thing, whether the children have antibody, which I think they do.
Yeah, we're collecting serum and urine specimens from children living in the same household as the pregnant women. So we're going to look at neutralization in these children. Obviously, they were probably not that viremic at that time, but that's something that if we get additional funding, we do have the specimens to do that and see if they've been infected through neutralization, looking at neutralizing antibodies.
And also maybe a higher proportion of asymptomatic cases in children and adolescents when you compare to adults.
Let's try to take one more question in the back.
Thank you. Doug Bryan, Melbourne, Australia. I was hoping somebody else would ask this question. What are the international public health implications of the Olympic Games soon to be held in Brazil?
Well, there's very little Zika in Rio right now. So we don't know if it's because everyone's been naturally immunized. The attack rate was very high, like at least in our cohort, it was over 85% attack rate, or it's just the weather change. You know, we're going into fall right now in South America, and dengue, for instance, is more prevalent in the summer, even though it can happen all year round. So we think that by August, there will be little Zika circulating in Brazil, if any at all. That's the optimistic perspective. But it is true because we have not seen cases of Zika in our pregnancy cohort. They're all turning out to be chikungunya. So at least in Rio, it is coming down, and people tell me the same thing is happening in northeastern Brazil. So we do believe there'll be hardly any Zika cases in the winter.
That's exactly my perception.
We'll try one last question, even though we're a little bit over.
Hi, I'm Vicki Bailey from Oklahoma City. I also just kind of want to address some clinical issues with the summer travel season coming. I've been asked a couple questions from the pediatric population. Do we need to, I'd like for you to comment at least on infant or young child acquired disease, and they're still developing brains, not congenitally acquired, but infants that might be visiting infected areas. Do we need to be concerned about that, other than like the risk of an encephalopathy that was mentioned, or Guillain-Barré, and then also in young women of childbearing years returning from vacationing in those areas, if they are asymptomatic from the disease, should they be tested prior to getting pregnant, or how long should they wait from coming from that type of a trip before trying to get pregnant?
To answer the second question, we do have recommendations for women of reproductive age that were released, I think, about a month ago. And for men that are returning that have been symptomatic, we're recommending, for man that is believed to have had Zika virus infection, to wait 6 months before before getting someone pregnant, and the timing for women is 8 weeks. So women, because we would believe the woman would have cleared the virus from her blood by 8 weeks. So even if she was asymptomatic or symptomatic, she would have cleared the virus from her blood by 8 weeks. Now men, we don't know how long the virus can stay in the semen. We know that there are reports of Zika virus RNA being there as long as, I think, 72 days. Yeah. And so for the sake of because we didn't have information for longer, right now we're recommending for men who were sick with Zika virus infection waiting 6 months.
If the men are asymptomatic, would you recommend them be tested?
No, because we don't have good information on the performance of the test in asymptomatic people, and so if they're asymptomatic, we are recommending an 8-week time period.
I see. Okay. And my question about the young infants, children?
We don't have any, we have very little information on young infants. We published a paper in Pediatrics, I guess about a month ago or maybe 2 months ago. Time is, I can't remember exactly, but the information we have is that it appears to be a mild illness, and I don't know, Dr.
That's exactly what we are observing. It's preliminary data. But so far, we are not seeing complications in infants or children. So apparently the disease in those age groups are clearly less severe when comparing to adults and less susceptible to neurological complications when comparing to adults.
Yeah.
No, I'm sorry.
We would still recommend that people take care to not get bitten by mosquitoes because there are other diseases that can be spread by mosquitoes.
Yeah, with the magnitude of the epidemic in Brazil, had there be any effect in small children and infants, we probably would have seen it by now, and that has not been reported.
Okay, well, please thank you and join me in thanking our speakers, who we really appreciate, and also for your excellent questions.